We have today's session on blueprinting. We all know what is a blueprint in constructing a house. When it comes to our education, there are some guidelines and protocols in making a blueprint for the purpose of assessment. Before we get into the session, let me have some few questions. On seeing a question paper, how many of you have felt this question should not have been asked like this? This question should have been constructed in the other way. This question is biased and has come from the same chapter or the region or the topic. And this question paper is a question paper setter friendly or student friendly. So these are all the questions that come across our mind when we look at a question paper. What is the reason behind this? So when we see to the reason for all these questions, it's all only because we are not aware of what is blueprint, or we don't have the correct picture of a blueprint, that is the setting of an assessment. So in this session, we are going to get the answers for these questions. At the end of the session, the participants should be able to define what is a blueprint, mention the purpose of blueprint, how to construct a blueprint, choose an appropriate assessment tool in developing a blueprint, and enumerate the advantages of blueprint. Blueprint. It specifies all the elements of performance relevant to the assessment so that the appropriate samples of activity and the corresponding methods can be selected according to their relative importance to the overall assessment process. To make it in simple, the blueprint will act as a roadmap or a map how to make a question paper in such a way it is aligned with the teaching learning methodologies and the competencies and the expected outcomes. The purpose of the assessment is to certify the competency of future practitioners, the minimum level of competency, to discriminate among the candidates for advanced training, to rank in a competitive exam. It provides motivation and the direction for learning, and it provides a formative feedback, and it gives a judgment for the training program. This is the purpose of an assessment. I think it's not visible. Yes. When we see to the purpose of blueprint, the blueprint, it helps in framing an assessment. It defines the scope of assessment. It decides on the weightage to be given for the particular content and the domain. It decides on the number of items to be included in a particular title. It helps to prepare a table of specifications. It helps to prepare individual questions. How do I make a blueprint for my assessment? First, we should define the purpose of assessment, whether it is a summative or formative, to decide on what competency or the rank we are aiming at, and to tabulate the curricular content. So, assessment, when it comes to the assessment, making a blueprint for assessment, first we have to decide on whether it is a summative or formative. And most of us are working in affiliated colleges or government colleges. We don't have the powers of extending the blueprint up to the summative level. But of course, many deemed colleges, deemed universities, they are framing their own blueprint and their assessment. So making this blueprint definitely will help us all, whether we are affiliated to the government or affiliated colleges or deemed universities, this blueprint will help us to make or to determine or define our assessment methods. So how to align this assessment and blueprint? For this, we have to go back with the curricular learning objectives, the teaching learning methods, assessment methods, and what is expected out of assessment. And as far as the medical education is concerned, we are now into this CBME, competency based. So we fix some expected outcome at the end of the course or at the end of the program. At the end of first year, what is expected from the teaching learning methods of anatomy, from the curricular objectives of anatomy, from the different methods of assessment of anatomy. So this first we have to frame it. And then we have to prepare with the blueprint. So now we all know what is Bloom's taxonomy, what is Miller's pyramid, what is happening at every level of these pyramids, and how we are going to teach them using these pyramids and assess them using these pyramids. Fine. How to allocate the questions or the marks onto the content, and what do we expect at the end of the assessment? That is the distribution of the weightage. All that is expected cannot be taught, and all that is taught cannot be assessed. That means across the period of 1 year, we teach so many things the students, and all the things whatever we teach, we are not assessing. And vice versa, whatever we assess, many a times we all feel that it has not been taught retrospectively. So the distribution of the weightage of different contents, the distribution of the marks across the assessment plays major role in attaining the expected outcome out of the assessment. In MCI document, it's very clearly given what is the weightage to be given to the different components of the assessment. In phase 1 and 2, we can give the weightage or the assessment type. It could be a clinical or a case-based and a subject-based. So how much of importance? Actually, I remember in one of the sessions, some resource person, they have given a pyramid, one straight pyramid and an inverted pyramid with the interpretation of basic sciences and clinical sciences in the preclinical years, and vice versa, the basic sciences and the clinical sciences in the inverted pyramid. So on that basis, in pre and paraclinical phase 1 and 2, how much of weightage we can give? When you see, for the subject based, it could be 20%, and the applied based can be 80%. And when it comes to third and fourth phase, the weightage has been divided into 3. Rarely seen or non-urgent cases, 10%. The serious or relatively common, 20%. The emergency or very common cases, 70%. So that's how the assessment part, the weightage, it can be divided among the phases of 1 to 4. That is one phase-wise weightage. When we look into the domain, we have 3 basic domains: knowledge, affective, and psychomotor. As far as anatomy is concerned, we say it has got more of knowledge domain than when compared to the psychomotor or the affective domain. So based on this, the knowledge can be given 80%, and affective 10%, and psychomotor 10%. And this affective 10%, we can take it from ADCOM. And psychomotor, we'll be seeing how we are going to give this 10%, allocate this 10% into the domain, that is in the preclinical year. In what area we are going to use this? When it comes to the paraclinical and clinical, the same thing differs in the reverse manner. In paraclinical, the knowledge is 60%, affective is 20%, and psychomotor is 20%. When it comes to the clinical years, it happens with a 10% clinical, 20% affective, and 70% psychomotor. Inside or within the knowledge, affective, and psychomotor, how the questions are to be constructed, if you see, the construction of the questions can be in the way of recalling or the remembering, the reasoning, applying, and analyzing. So the applying, reasoning, and analyzing will come in the part of case-based one. The recall will be a simple remembering one. An affective domain, it involves or it can include with the receive, respond, and value. The ADCOM modules, we all have the ADCOM module in which every module has got some component, their behavior in the dissection hall, how they handle the specimen or the cadavers, how do they behave and their behavioral thing in the dissection hall, and in the histology, how do they handle the histology slides and the microscope, everything matters here. And the psychomotor will be imitation, manipulation, precision, and articulation. So all these things, mostly the psychomotor, we will be testing them in the practical. So one by one, we will just get into it, how we are going to distribute all these. So one classification or the allocation will be on the assessment type, the subject based and the applied based. The other one is the domain based. So now coming on to the phase 1 and 2 in the theory, how are we going to construct the question or going to make the blueprint? So we can go with the clinical or the case based or the problem based in case of long answers, short answers, MCQs, and reasoning. Most of the MCQs will have a case based one with the 4 options. In a subject based, 1 or 2 word answers and MCQs. So as far as the cognitive is concerned or the theoretical part is concerned, how we are distributing the questions, if you see, the applied or the case based, it can be incorporated into the short answers, MCQs, and reasoning. The subject based can be in a 1 or 2 word answer and an MCQ. 1 or 2 word answer, if you see, for example, we can do with the blood supply of thyroid gland. So here, just if they mention the 2 arteries, that will be more than enough for a subject based. Coming on to the practical, that is the affective or the psychomotor. Here we have, one is an applied one, that is the OSPE. The subject based one, demonstration on the prosected specimen and the demonstration in surface anatomy. So here we have the subject based. OSCEs can be, the OSPEs can be set in a stations. In phase 3 and 4, based on the weightage distribution, the blueprint should be prepared with a long answer, short answer, and a disease based. The practical, it will go with the OSCE, mini CEX, bedside, and the DOPS. And these things we are not going to concentrate much on this part 3 and 4. The phase 3 and 4, we are going to go with the phase 1, where we have the theoretical part and the practical part. So now we have seen how we are going to go about with the blueprint, what are all the things to be given importance, and what weightage allocation according to the components or the contents. The characteristics of the blueprint, if you see, it should be a measurable one, it should be a reliable one, it should be feasible, and it should be valid. This is most important. Measurable. While making the blueprint, there we have to have the mark allocation, and the structure of the question should be very appropriate with the allocation of the marks onto the every component of particular item. And reliable, all the questions whatever we are making or all the items we are constructing in a blueprint, it should be a reliable one. That means it should be from the portions what we taught them. It should be a feasible one, means it should be able to be followed by the institution where the blueprint is being implemented. And it should have a validity. That means the outcome of this blueprint assessment should be valid to assess or to confirm the outcome, the quality of the outcome. That is the characteristics of the blueprint. When we see to the advantages of the blueprint will link the SLOs with the assessment. It will mainly focus on the expected outcome. It will cover the entire syllabus, or it has to cover the entire syllabus with main emphasis on core areas. It will help to overcome two major threats in the validity of the assessment. This is the most important thing in the blueprint. When we see to the advantages, these are all the advantages. And the most important one in making the blueprint is it will help to overcome the two major threats, that is the CU and CIV. We'll see here what is a CU and a CIV. CU is the construct under representation and construct irrelevant variance. So these are all the two new terms we are not familiar of. Means like many people would have heard about this, many people they know about this, and for the few people who are new to this, we will just get to know about what is construct under representation and construct irrelevant variance. First, construct under representation. This means the blueprint or the question paper is a biased or undersampling of the content. What does it mean? We would have come across, we all have come across some question papers which is framed with the questions taken from one particular chapter or the region, leaving off the other region. That means few items from a vast area and major items from a less important area. So as far as anatomy is concerned, we all agree that we say the clinically important region or the topic or the chapter, we say it is the abdomen, pelvis, perineum, thorax and head and neck. This is what we all feel in common. So there are some question papers which will have very less questions and less important questions have been taken from the abdomen pelvis region, and more of less important questions from the non-important regions. That means if there is a paper with upper limb, lower limb, abdomen, pelvis, perineum, if there is a case or if there is a question that comes from the upper limb of a topic which is not at all given more importance when we teach, and that chapter or that topic is given as an essay question, and what we feel the most important one in the abdomen, pelvis, perineum, if that is given as a one small bit in that question paper, that we say it is a construct under representation. And construct irrelevant, that means uncontrolled or unrelated variables which will affect the outcomes. This happens when the following are present in the assessment, that is the assessment content: the poorly constructed questions, the test wiseness, guessing, item bias, testing irregularities, indefensible passing score. The poorly constructed question, very ambiguous question. There is no specific reasoning in the particular case. When you construct a case, when there is no reasoning part or when there is no clear cut of the clinical symptoms, that is said to be a poorly constructed one. And test wiseness. Based on the test, what is we are aiming at, the question is not constructed on that particular thing. Very vaguely has been taken from in a haphazard manner. And giving an MCQ with the inappropriate clues, that will lead the person who is attending the test to a guess. So without understanding the question, they'll just make a pinky ponky and they will guess the answer and they'll answer it. And item bias. There will be a bias in the choices, like none of the above, all of the above, like that and all. If the options are there, that will be an item bias. And testing irregularities. This testing irregularity is the one who is constructing the paper will be a different one, and who is assessing the answer paper will be the other person. This is testing irregularities. An indefensible passing score. That means the question paper will be too easy to pass or it will be too tough to pass. This we call it as an indefensible passing score. So now coming on to the theory. Based on some deemed universities who have constructed their blueprint, this is the mark allocation they have given for theory. The 1 and 2, 100 marks, practical 80 and Viva 20 marks. And after the session, I'll be sharing in the GCR some of the blueprints of some deemed universities, which you all can go through and you will get a better idea than the session. By applying the contents of the session, you all will be able to understand with the help of the blueprint posted in the Google Classroom. So the theory part, it's been divided into MCQs, long answer, short answer, and brief answer. The MCQs, at least 5 of the questions, it should be a case-based one. And in a long answer, normally all the universities will have 2 long answers, of which one should be a constructed one or a structured one. The other one should be a case-based one or a problem-based one. And the level of domain, if you see, the knowledge, comprehension, application, and analysis. Depending upon the number of questions, we can take the questions in such a way. 2 can be a knowledge-based, a direct question. And 1 can be a comprehension, understanding and applying, and analyzing. So most of the application and the analysis will come under a problem-based or a case-based one. The various levels of cognitive domain, which has to be considered on this basis, the cognitive domain has got a knowledge, comprehension, application, and analysis. And here is the mark distribution of another university. Some universities, they have a distribution like this. Some university, they take a distribution like this. And this is one typical blueprint of a deemed university, which has a split up of marks in this manner. Head and neck, long answer, short answer, MCQ, brief answer, total marks. For the same thing with the thorax, histology, systemic embryology, and the total marks. So this is how they have made a blueprint. And now, coming into the head and neck, what they say here is 2 into 5, that is equal to 10 marks. That's how they divide. So from head and neck, they'll have 2 questions. And from thorax, they'll have 1. From systemic histology, 1. Like that, they have divided under each region. So that is the short answer. That's how they construct the blueprint. They have constructed the blueprint. Coming on to the practical. In practicals, where we all have the gross anatomy and histology, this is the common template we all are following. Spotters, discussion, and the total marks. And the discussion, we take it for 10 marks, one from paper 1 and paper 2. All these are the common things or the regular things what we are all following. The new item included in our practical is the OSPE, Objective Structured Practical Examination. So here, some new things have been added or constructed by some university. One is the testing of the action of muscle or the movements of the joint. I think most of us have not followed this type of OSPE because we all know to set up a station, OSPE station, where we keep a clinical case. We give 5 questions. And that 5 questions will be, out of 5, 2 or 3 will be a clinical based one. That's how I think many of the colleges, they are following the OSPE pattern. And this is one different OSPE pattern where they have a station for the testing of action of muscles, the live surface anatomy, either on a cadaver means or in a subject. The live surface anatomy will be a subject where we need to make a bony landmark or the palpation of the blood vessels. Normally, we used to have the surface anatomy on a cadaver. So this is one different type. And genetic chart, problem solving exercise. So everything comes under, again, the same thing, the knowledge, different levels of knowledge. And one will be the, few will be the psychomotor. Testing of action will be a psychomotor. The live surface anatomy will be a psychomotor. The genetic and the problem solving will be a application and analysis. So these are all the various components what we need to understand while making a blueprint. So in a nutshell, while making the blueprint, we all have to keep it in memory, the division of the domain and the division of the subject based and the application based. So with these things in mind, if we construct the blueprint for an assessment, definitely it will help the students to be like attending a treasure hunt, and they will enjoy the fun of finding out the answer. So with these things from the session, take home message, an activity can be there in every group, in each group, to choose a chapter or a region. You can prepare a blueprint on your own, on theory and a practical. So with this, I conclude the session, and we will go for a questions or discussion. I think our resource persons also will be able to facilitate you all with all your questions. Thank you. Deepthi ma'am.
Yeah, Dr. Girija, I think you have to unmute everyone so that they can unmute themselves. Dr. Kannan has raised the hand.
Yes, ma'am. 1 minute, ma'am. I'll just.
Yeah.
Ma'am, I have an option only of mute all, allow participants. Okay, I'll do that. Okay, now, ma'am, I have made all the participants, they can unmute themselves.
Hello, good evening, ma'am. Hello. Am I audible?
Yes, Dr. Saikat. Dr. Girija?
Yes. Ma'am, I just want to know about the item bias. Will you please clear it again?
Dr. Girija?
Yeah, Deepti ma'am. Ma'am, I'm
Yeah.
not getting his question, ma'am.
Item bias you said, no? Earlier.
Yes. Yes,
Bias that I think construct irrelevance variance. That bias that can occur. He's asking, what is that item bias?
1 minute.
That too few items of, you know, like when you give too many from one chapter, too many questions from one chapter.
Yes, ma'am. I'll just go. Shall I go to the slide?
Yes, yes.
Girija, that all of the above or none of the above, no? I think that is.
Oh, okay.
Yes. Yes, ma'am. So this is the one he's asking item bias, right?
Yeah.
Yes.
Yes, yes,
Okay. Yes. Yes. So when you're constructing the essay question, for example, we are taking a head and neck region. Okay. So in the head and neck region, we have to construct 2 essay questions. Supposing some questions we have seen, one will be on the dural venous sinus. And the second question will be on the internal jugular vein. So the essay questions, if you see, they both are concentrating only on the venous system, and that too the internal jugular vein, we say it is a less important one. So there what happens, there is an item bias. So in the head and neck region, which is a vast one, the question is not being spread across the entire head and neck region. Rather, they have taken the question, they have constructed the question in such a way, both the questions are concentrating on one structure only. Rather, it could have been on a facial nerve, or it could have been on any other topic or any other chapter, instead of taking the internal jugular vein. That is item bias.
Okay, ma'am. Ma'am, another thing, you gave one example that when we construct an MCQ like all of the above or none of the above, which kind of bias is this?
That is also a item bias only.
So why we are calling it a bias, ma'am? Is it not right to form the MCQ like that? All of the above or none of the above like that? I just want to ask you that.
In the same MCQ, we should not give them a chance of all of the above and the none of the above. Both the things should not be there. So then what will happen? 1, it will be an item bias. 2, it will be a guessing. The students will guess because they do not know what to choose among the 4 options.
Okay, now it's getting clear. Thank you, ma'am.
So actually, construction of MCQ itself is one separate chapter where there is so many things are there to construct an MCQ. There is a stem, distractor, all those things are there. So if you have any session on that, you will better understand with that. Where we insist very clearly on none of the above and all of the above should not be the choices on the same question.
Hello, ma'am. Hello, ma'am.
May I?
Yes, ma'am.
Ma'am?
Can I ask ma'am one question?
Yes.
Yes, ma'am.
Hello.
Ma'am,
Girija, ma'am.
Yeah.
Yeah. May I ask you, actually, is there any formula for the blueprinting of particular? Is there any formula?
Yes,
or we have to ask something from the core area and the non-core area?
Yes.
Is there any formula?
Yes, ma'am. There is a formula. Hello.
We can hear you, Dr. Girija.
Ma'am, please explain that. Yeah.
Yes, ma'am. There is a formula actually. And that formula only made it simplified as 80% and 20%. Core area and non-core area. I'll be sharing a blueprint. There is a blueprint of 2 universities. Hello.
Gunapriya ma'am, can you
No,
please mute?
that is fine. That the core and non-core
Except Kanansha and us, all the others are muted.
I think Dr. Manjari's Manjari is on. Can you please mute Dr. Manjari?
I'm just looking for the name, ma'am.
Formula.
She
how
muted,
much,
She's muted.
Yeah.
we have to
Okay,
ask
okay.
from
Dr. Girija, I think Dr. Kannan is asking about impact and frequency, that formula. Dr. Girija?
Ma'am, can you hear me?
Yeah.
Yes.
I think Dr. Kannan is talking about the formula for...
I'm not hearing any voice clearly, ma'am.
Okay, shall I share? I have one about weightage and frequency.
Yes,
Shall I share the slide?
Ma'am?
Can I share? I have a slide.
Yes.
Dr. Kannan is actually asking about impact and frequency and the formula that is used to find out the weightage. So shall I share?
Yes, ma'am.
Okay, can you permit me to share?
Yes, ma'am. 1 minute. Yes, ma'am.
Okay. Can you see?
Yes, ma'am.
Okay. Dr. Kannan, please check if this is what you want.
yes, ma'am. Please.
So when we make a blueprint, we can start out with what Dr. Girija said, the purpose of assessment, whether it is summative or formative, and the learner is first MBBS. And then you can take a topic, like for example, I put here axilla, shoulder, and scapular region, and then make a table. What is the competency number and what is the competency? And then you have to calculate the weightage based on impact and frequency, the formula that you're talking about, Dr. Kannan. So Dr.
Yes,
Gita has already mentioned, these are called as frequency. Clinically, if it is a rarely seen case, for example, in axilla, if maybe some enlarged lymph node due to a rare infection, okay, that is rarely seen, it gets weightage of 1. If it is relatively common, enlarged lymph node due to infection in the region of axilla, 2. Very common, CA breast, enlarged axillary lymph nodes, give weightage 3. Okay, for this, you need to discuss with the clinicians and a number of experts in the subject to come to what is the frequency. Okay, then the impact. Now, if it is a clinical subject, like Dr. Girija mentioned earlier, she's not focusing on phase 3. Okay, so if it is phase 3, then the impact would be non-urgent, serious, life-threatening. They are allocated marks 1 to 3. So this is called as impact. The previous one I'd shown is frequency. So when you come to non-clinical subjects, the impact would be a topic that we take which has no or little clinical importance is allocated 1 mark. If a topic has moderate clinical application, 2 marks, and topics with high clinical application, 3 marks. So you know what is frequency and impact now. So you now take a total, that is sum of the impact and frequency. Weightage, when we say weightage for a topic, the formula that is used is impact into frequency divided by the total. Total is impact plus frequency. And then you go to a table, you write the topics, and now since it is competency based, you can put the competencies. Then what is the perceived impact? What is the frequency for that particular topic? Then you put impact into frequency. Weightage is impact into frequency upon the total. And then you take the total number of marks. For marks, how do you calculate marks? It is weightage into 100. When you get weightage, it comes up to 0.9, 0.1, actually it comes up to 1 when you add all the competencies of a topic. And finally, you have to get 100 marks. Dr. Girija has already told you how many questions you can ask, what type of questions you can ask, and what marks can be allotted. So if you do this weightage, before allotting all those marks and how many questions you will ask from a particular topic, you have to follow this formula in order to get this 100 marks. Okay. So Dr. Girija has told the next step. One essay, what is the marks of your university you put, short notes, brief answers or MCQs, so that this is each section where 40 marks are there. Then, so 40 plus 40 is 80 and then 20, so 100 marks. So once you do this formula, you'll get a better idea on how to give the marks. Dr. Girija has shown the next step, where she showed how many questions, essay from upper limb, how many short notes from upper limb, how many 2-mark questions from upper limb to get a total. That total comes in N is equal to W into 100. Okay. Dr. Kannan, does it answer your query?
Yeah, thank you
Yeah.
so much, ma'am. It's very well cleared. Thank you so much.
Thank you. Dr. Girija, I've stopped sharing.
Yes, ma'am. Okay. Yes, ma'am. Thank you, ma'am.
Hello, Giri.
I don't know why the signal is going on and off for me, ma'am.
I think now Dr. Anjali wants to speak, I think. Or Bhavna, Dr. Bhavna or Dr. Anjali?
Yes, Bhavna here, ma'am. Can
Yeah,
I?
okay.
Yes, ma'am.
Yeah, ma'am. In that CIV, that construct irrelevant variance, there one query I had that can you explain the test-wiseness, ma'am?
Test-wiseness is what is the type of test you're going to give them? Means like, take for example, you're giving a test on abdomen.
Okay.
So means like in constructing the blueprint in abdomen, the questions, it should be based on the type of test what you are going to or what you have planned for them, and based on that only the test questions it has to be constructed.
Okay.
Say for example, when you want to test the psychomotor or the affective domain, and your questions also should be on that basis only. For that you cannot go for a domain, means like the knowledge domain questions.
Knowledge domain. Okay.
Yes.
Okay. Okay. So questions should be relevant to the type of test which we want to conduct.
Yeah, exactly.
Okay. Ma'am, another one question. When you discuss the weightage for the phase 1 students, and then you talked about the theory paper, that how much LAQs from clinical based and from the subject based. So mainly there the LAQs, SAQs, BAQs were from clinically oriented topics, while only MCQs and one or two words answers were from subject based. So for phase 1, is it that major paper should come from the case based or clinical based, ma'am?
No, madam. I gave that subject based 1 or 2 means within that item we are giving the variables, right? For example, short answer questions. Supposing if your university is having 8 short answer questions, out of that 8, the distribution should be in this way: clinical based 80%, sorry, subject based 80%, and the clinical based 20%.
Okay.
So when we split among the 8 questions, this type of percentage, then you will have only 1 or 2 questions.
Okay. Understood, ma'am. Thank you, ma'am.
Yeah.
Very beautifully explained. Nice lecture, ma'am. Thank you.
Thank you. Thank you. Ma'am, any more questions, ma'am?
Not exactly. 1 second. Let me check.
Nobody has raised hands so far.
Yeah.
Yeah, Dr. Gunapriya ma'am have given one statement. For phase 1, it is advisable to follow single best response. Exactly, ma'am. Even I feel single best response only will be the good choice for the phase 1 students.
The other types of MCQs can be tried only for competitive exams.
Exactly. For the NEET exam and all.
Yes, exactly.
Yes. Ma'am, any questions, ma'am?
Not at
Praveen sir has raised his hand.
Okay. Yeah.
Just wanted to make a comment regarding discussion going on regarding MCQs. It is just a matter of how our assessment system is. If we feel that the other types of questions like the long answer questions, different types of short answer questions, and single best response serve our purpose of assessing all the levels of cognitive domain adequately, if that is our perception and our satisfaction, then we may restrict ourselves to a particular type of multiple choice question. But if we feel that we require different types of multiple choice questions to make sure that we reach all levels of cognitive domains to be assessed, then definitely there is no harm in making an attempt, especially in the formative assessment, because we can take it to a higher level in the formative assessment. The summative assessment is driven by the university, and it takes into consideration a lot of factors. So therefore, I think in summative assessment, we can restrict to the common varieties of MCQs. In formative assessment, at college level, we can definitely try out multiple types of MCQs.
Thank you, sir. One request to the participants. I think many of us are going as a question paper setter to the university. So now all the things are in our hands only. When we go for the setting of a question paper, we can have all these points of blueprinting in mind. And when we construct the question paper in that way, then it becomes the practice of the university overall. So if we all put together our efforts in making the blueprint, whether we are deemed or affiliated or government colleges, when we have this point of thing in our mind with the blueprinting, definitely it becomes get implemented into the university level also. It's a small request.
Okay, another point has come to my mind here. I'd like to share. All our current assessment system followed at all universities in India is the formulation of an assessment is done by, say, an individual person. For example, a paper setter is appointed individually. Then on top of it, the moderator is appointed individually. So therefore, what happens is, considering that the person is qualified and an expert to do the job single-handedly. But the general principle, especially in the construct of the questions, is that the questions are constructed by a person single-handedly, and the process of pre-validation has to be done by 3 or 4 people sitting together. Unfortunately, this concept more or less remains either the college level itself at some places, not at all places, and it never gets translated into a summative assessment. So, in addition to emphasizing on blueprinting, probably the system also should approach towards this particular aspect. And as more and more universities accept multiple choice questions in their theory assessment, this is more and more important. Otherwise, what happens is every question is becomes a matter of guesswork, and if pre-validation is done properly by 3 or 4 people, then the question is looked at into all angles using a proper checklist for construction of items. I think that should be our ultimate aim in future, in addition to taking the blueprint concept ahead and summative examinations.
Correct, sir. You're very correct, sir.
At least this can be started in the departments at institutional levels for sure. And to share, in our department, this is the policy that has been followed since probably, I don't know, n number of years. I have seen it at least from the day I have joined. Even before that, it must have been continued for sure.
Nice.
Dr. Girija, Dr. Sheila has asked if Bloom's taxonomy, levels are followed. What is the percentage of distribution of different levels of Bloom's taxonomy in theory question paper of summative assessment?
Yes, ma'am.
It is there. I think you had a slide.
Yes.
Knowledge comprehension, application, analysis,
And analysis.
NCI document.
Yes,
I think
ma'am.
you have.
Yes, ma'am. Should I share?
Yeah, I think so.
I think out of yes.
Yeah. I think percentage is given, Dr. Girija. Knowledge, no, it is 20%, comprehension 20%, application 20%, analysis 24%, synthesis 8%, evaluation 8%.
Okay.
This is what
But synthesis and evaluation in preclinical we don't have, no, ma'am.
Yeah, that's true. But NCI has given this.
Yes.
Of course, they have not mentioned it's for phase 1, phase 2 or so on.
Yeah, exactly.
Yeah.
So at the most we can go up to analysis level, application and analysis. That's all.
Right.
Analysis will come under the case solving.
Yes.
Yes. So approximately we can have the percentage in this way.
Right. No more questions, actually.
Okay.
Punita ma'am has raised her hand.
Punita ma'am, yes ma'am. Unmute yourself, ma'am.
Punita ma'am.
Punita ma'am.
Oh, yes. Hello.
Yes, ma'am. You're audible, ma'am.
Yeah. Good evening, ma'am.
Yes,
Dr. Girija ma'am, a very nice, very crisp and clear presentation.
Thank you, ma'am.
And very good discussions also. I wanted to clarify one more thing is regarding the non-core competences. Is it that the non-core competences are to be assessed in formative assessment only? Because in our university, we have categorically mentioned that only core competences will be in the summative assessment.
Yes, ma'am. That is what the core and non-core informative, we can have any type of assessment. When it comes to summative, it depends on the particular university, whether they're doing it on core or non-core. Some universities, they do on a non-core also. Deepti ma'am?
Yeah, non-core, we have allotted. Our university has given importance to non-core as well in summative assessment as well. So yes. MCQ or 2-mark question we give from non-core.
Okay.
Yeah.
Because I know it was particularly mentioned in our departments and the 3 departments that don't include non-core in the summative, so that it's.
Ma'am, we had discussed earlier, no? Brachial plexus, I think. Yes, ma'am. Ma'am, we had already had a discussion. I think brachial plexus or something, Klumpke's paralysis or something was given as non-core. Praveen sir had mentioned then. Like clinical aspects, most of them have been given as non-core. But CBME is supposed to be clinically oriented subjects. But somehow they are given applied aspects as non-core. So.
Yeah. Yes, ma'am. Thank you, ma'am.
In the MCA document, many of the clinical conditions are discussed as non-core.
Non-core.
I don't know why he has given it like that.
Yeah, that's what.
And in fact, all those we teach usually. In the applied aspects, we teach usually all those clinical aspects.
Yes, exactly.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am.
That's all, ma'am. Nobody else is there. No other hand raised, ma'am, or unmuted.
Okay. No hands raised. Deepti, ma'am?
Yeah, nobody has raised. Today we are closing at 8:05.
Yes. Exactly 1 hour, ma'am.
Yeah,
Not bad.
Yeah. There are no messages on WhatsApp as well.
Yes, ma'am.
Yeah. We'll close the session, ma'am.
Yeah, I think Sanjay Bedi sir is there. We can ask him.
Sir Bedi, sir?
Yes.
Sir, session over. Shall we close?
Yes, you can close.
Okay. Thank you, sir. Thank you, all participants.
Thank you,
Any
Dr.
queries or
Girija.
any questions? Yeah, thank you, ma'am.
Thank
It was
you,
very
ma'am.
good.
Thank you, ma'am.
Okay.
Thank you.
Very nice session.
Thank you, ma'am.
Thank you, Girija. Very nice session that was. Thank you very much.
Thank you, ma'am. Thank you.
Thanks to all and good night. Bye-bye.
Good night, ma'am. Bye.